laryngeal preservation is certainly an organ to preserve. And having laryngectomy is a traumatic experience. And so I think that there's a lot of desire to continue to decrease laryngectomy numbers. And so this is a nice, healthy larynx, nice, moist mucosa, no edema, no fibrosis. You can see your piriform sinuses, you can see postcricoid space, laryngeal surface of the epiglottis, and everything is as you would expect it. And so we can kind of keep that in mind as we go further and talk about not normal larynxes. And so we can talk about surgical options for laryngeal preservation, as well as the trials that paved the way for current paradigms in treatment, and then chemoselection, as well as salvage procedures. So there's a lot of reasons to preserve the larynx, especially for patients who have difficulty maintaining a laryngectomy, as well as for all of the quality of life issues, like voice and swallowing, as well as even something that we often don't talk about is just a sense of smell. So primary surgery can be used to preserve a functional larynx. So TLM is a surgical technique really started in Germany, and TORS has a more limited role, but that may be expanding with single port access, as well as open partial laryngectomies. So a case series looking at 90 patients that had TLM for their primary tumor. Most of them were early stage.
The timer is not running.
Oh no, Siri's trying to get down on me. Okay. And you can see that the local control is very good, especially for early stage disease. And that kind of drops off for T3 lesions. There is also robotics laryngeal surgery, which is primarily for supraglottic tumors. So you can see this, it seems almost like post-radiated larynx, where you're having a supraglottic laryngectomy, and here at the end, you can see our laser-safe tube with two kind of edematous vocal folds present. And then this is the tongue base under the retractor. So there's limitations in terms of getting the instruments into place, and the patient has to have very good exposure to make this happen. And so there's even discussion about doing a total laryngectomy with partial robotic exposure, mostly to avoid exposure of the carotid sheath, as well as decreasing the extent of mucosal incisions. And so there's a lot of history in the non-surgical approach for laryngeal preservation. So the Veterans Affairs trial in the 1990s randomized around 300 patients to upfront laryngectomy with radiation, and then versus an induction regimen followed by radiation therapy. And so they had 2/3 laryngeal preservation. But they saw that the T4 laryngeal lesions did not benefit from induction chemotherapy. So that kind of paved the way for further studies to exclude T4 lesions from non-surgical trials. And so you can see a pretty even parity for survival for radiation versus, induction chemo plus radiation versus upfront laryngectomy. Then there's the RTOG 9111 study. Let's see. Hello? Hey, hi. Yeah, this is me. Is this, yeah, could I just give you a call back right now? I'm just giving a lecture. Thanks so much. Bye-bye. For these patients, they were randomized into 3 groups, and with a long-term follow-up, patients that got combined chemotherapy and radiation therapy had up to 84% laryngeal preservation. It was fairly similar with an induction regimen followed by radiation, and radiation alone had even lower laryngeal preservation. And so for this study, they did exclude patients with T4, large volume T4 disease. And the they did have better survival, again, for the concurrent chemoradiation, which is why we do that today. And so interesting data for long-term survival from this RTOG 9111 trial. So we have radiation therapy plus induction in the blue, and concurrent radiation and radiation alone. And there was you could see the splay here at the 3-year point with best survival with concurrent radiation, and you could see that the non-cancer deaths were highest in the concurrent chemoradiation group. And so there's kind of an idea that that there are long-term functional effects from the intensity of chemo radiation delivered concurrently. So for T4 tumors, non-surgical therapy is really not accepted at this point, but there are patients who do reject laryngectomy. So I got 2 different studies that looked at the National Cancer Database, looking at for patients.
A little bit. We couldn't hear you for a little while. I think the internet cut out.
Yeah, I saw a little warning on the internet. So you want to go back to the last slide? Let's see.
Yeah.
So I have 2 studies looking at the National Cancer Database, looking at T4 tumors specifically. And so it's not really ethical to randomize these patients to have non-surgical therapy, but patients do reject laryngectomy even when they're offered. So we can kind of study those patients. And so we have 1,500 that underwent surgery followed by radiation, and then another 1,500 that had concurrent CRT, and then those that underwent induction chemotherapy followed by radiation. So as we expect based on our current practice, the overall survival was improved in patients undergoing upfront laryngectomy plus radiation. So we can see that it's not a major difference, but the surgery did better, especially at earlier time points at 36 months for overall survival.
Dr. Leapman?
Yeah.
So what'd you say? So if they have a patient that rejects the laryngectomy or whatever, not a good surgical candidate, induct?
Yeah. I guess it's a question of, I think the National Cancer Database, the
question. Were the results the same for induction chemo plus radiation versus concurrent chemo radiation? Like what is better for someone that can't do a laryngectomy?
Yeah, so that's a good question.
But doing it induction for some of these patients.
Right. I mean, so we'll talk about induction a little bit later, kind of the chemo selection. I think essentially, essentially these things are fairly equivalent, but they're going to be inferior to surgery upfront for these T4 lesions. So I don't think it makes a big difference if you do induction versus concurrent chemoradiation for a T4 lesion. It just, I think the biology of it just doesn't have good cartilage penetration, and it just doesn't work.
T4 concurrent is definitely better, but I didn't know for T4 if there was a little difference.
For T4, if there's a difference.
Like if induction is better for the T4s.
I don't think so. I think it's just used as kind of a chemo selection method. So yeah, actually in all studies that I know of, induction has never been superior to concurrent chemoradiation, I think, for any disease site, as far as I know.
Okay.
Yeah. But so that's why induction is kind of controversial, but University of Michigan is very much into chemo selection. And so here's another more recent study that looked at 8,000 patients with with stage 3 and 4 laryngeal cancer. And so they kind of did a little different look at the National Cancer Database. They looked at patients that had non-T4 lesions with low tumor burden. And so no matter what you use, whether it was upfront laryngectomy versus chemoradiation versus induction chemotherapy, there was really no difference. And for patients that had non-T4 lesions with a big burden of nodal disease, chemoradiation was beneficial. So it's kind of, I guess it's kind of showing just a little bit of difference in the biology there. Yet and this is another confirmation, again, for any kind of T4, no matter what the nodal disease was, the hazard ratio was 0.8 that favored total laryngectomy. So for these patients, it's kind of interesting that nodal disease benefited from chemoradiation versus T4 disease benefiting from upfront surgery. And I think it's kind of the same thing that we talk about for oral cavity. I think it's just the delivery of radiation and the penetration is just not as good when the laryngeal framework is involved. Because again, I don't think there's anything biologically different about, if you leave a T3 tumor long enough, it's going to become a T4 tumor. But there's something about that, I think, the penetration that's the issue. But, it's kind of interesting, when we talk about all of these, let's look at this. When we talk about all these different treatment options, there has been some fluctuation over time. Chemoradiation, certainly increased as a primary treatment option in the early 2000s, and then has kind of leveled off and maybe even slightly decreased. And total laryngectomy certainly decreased in the early 2000s, but then is a little bit on the uptick. And so the reason that in terms of advanced laryngeal cancer, there has been a decrease in 5-year overall survival since even the 1980s. So the feeling was that we were doing too much chemoradiation for patients that just weren't appropriate. But I mean, I think it is interesting overall that it's not like apples and oranges in terms of the survivals. The survivals are fairly on par, but certainly inferior if you're going to use a non-surgical treatment for a T4 lesion. So I think it's not insane to do a induction or concurrent chemoradiation for a T4 lesion, but it's certainly not your first option. And so this is a little bit about induction chemotherapy, and we kind of talked about chemo selection and maybe where things will go in the future. So there is, so there's various different studies that could be designed for chemo selection of T4 tumors. There's different regimens like cisplatin plus 5-FU, and in this particular study, they looked at, they did an endoscopic evaluation, and then for patients that had a partial response, they went on to chemoradiation, and for those that didn't have a good response, they went on for salvage surgery. And so, additionally, those with complete response were put on a chemotherapeutic regimen. And so salvage surgery was possible for these patients as well. So for these patients with T4 tumors, these were kind of like grouped from other studies as well. So I was explaining that those that had less than a 50% response underwent laryngectomy with postoperative radiation. So, there is a pretty high response rate. So the majority of patients had a greater than 50% response to induction chemotherapy in T4 tumors. It's not as high maybe as the R2G 911, but they were able to have, majority of patients have laryngeal preservation. And then they looked into some kind of functional aspects as well. Like, I guess the question is about, all of these studies is, what are we really doing with laryngeal preservation? And I think we talked about this in tumor board. If the patient's larynx wasn't functional before you started treatment, there's a good chance they're not going to be functional afterward. So, when you're doing organ preservation, what's your real goal? If you don't have a functional outcome, then maybe you haven't really helped the patient. So you're looking at, majority of patients were able to have intelligible speech. Majority were free of gastrostomy, and we're able to be free of their tracheostomy. But there's certainly a reasonable chunk of patients that have some functional impairment. And so I think as studies go on in the future, may have some more interesting combinations of induction regimens. And I think induction is, and I probably said this before, is a very kind of clinically reasonable method to use because getting a patient scheduled, for instance, for a laryngectomy, it takes some time. It could take a month or so to get them on schedule. But if it's, and so you leave yourself time to give them an induction regimen right then. So maybe in the first week of diagnosis, the patient could be started on a cytotoxic regimen, and plus or minus you could add in immunotherapy. And further, and then be able to go on to surgery for those patients that need it. And so this is another summarization of the various induction trials. So for the VA study and RTOG 911, you can add up the complete response, that's the CRs, and the PRs, partial responses. You can see that for cisplatin 5-FU, the response rate is pretty high, up into the 80% range. And then they also, kind of discussed, I think, a unique perspective that more recently used one cycle of induction, and they kind of thought that that was a better predictor because perhaps if you heavily treat patients with like 3 cycles, for instance, more of them will be responders, and so you're perhaps having less, you're being less choosy about your chemo responders. And for those who have like a response after 1 cycle, maybe it's an indication that they're very brisk responders, and that's kind of a, so I think that's, still may not be standard, but is kind of an idea behind the chemo selection thought process. Any questions so far? All good?
Yep.
So again, building on what I said before, a lot of this is about function. I mean, if you're making a laryngeal cripple, it's not that much of a favor you've done. So for patients that have vocal fold fixation, so let's see, Ethan, are you there? So if you have vocal fold fixation at the time of diagnosis, what T stage would you have?
At least 2.
But like, let's say total, like real fixation, not like a partial, not a partial weakness.
Fixation, I think, would be, higher than 2, obviously. I'm going to go, well, it's at least T4.
Let's knock it up to T3. How about that?
Right. Happy meeting.
Yeah, so you can have, so if we're talking about T3 patients with laryngeal fixation, most of them are going to be tracheostomy dependent afterward because it's just a good sign that you can't abduct your larynx. And if you start adding in radiation edema, it's just going to give you a limited airway. And patients are going to be oftentimes gastrostomy dependent as well. And so if you have a functional larynx, if you're able to speak clearly and swallow at the time of diagnosis, even if you have an advanced tumor, most likely you're going to be free of a gastrostomy or trach. And it is kind of interesting that patients can recover vocal fold function after CRT. And I've also heard in other studies that that have examined whether a patient recovers vocal fold function as a kind of predictor of disease-free survival. Because it's a very good indicator that the disease has been dealt with. And so there's different grades that you can use for the laryngeal dysfunction after radiation. So when you have a patient that comes into the emergency room after finishing radiation therapy and they have stridor and you need to trach them, they may have radiation chondronecrosis. So that would be a grade 4 type of laryngeal complication. Whereas grade 1, you pretty much see in everybody. They are going to have perhaps some level of hoarseness and edema. And so here's an example of a patient that has, you can see there is some edema of the arytenoids, and they have FDG avidity with their initial tumor. And then after treatment, they still do have some residual edema, but the laryngeal function in this case was improved. I think that we're seeing some medialization here of this right arytenoid, and so that's, I think, been partially regained. And so chondronecrosis is a loss of blood supply to the cartilage, just like osteonecrosis is for the mandible. And so, you know, I think there's certainly an idea about if you, for instance, do like a TLM procedure and you leave cartilage exposed, you know, does that make the patient a higher risk for chondronecrosis? And so for these patients, it can be a great cause of pain and laryngeal dysfunction, and often lead to a functional laryngectomy. Laryngeal edema is another finding. So it becomes really hard to actually see the glottis. And so there is actually a staging scale. I think we talked about this before, maybe some other time, for lymphedema. Are you guys familiar at all about the staging scales for lymphedema of the neck and for the endolarynx?
No.
Yeah, just for research purposes, but yeah, it's hard to, it's subjective, but at some point I was putting it in my notes. But there is the Patterson scale, I think, for the neck, and then the Foldy, FOLDI scale for the endolarynx. And so, yes, I think this would be an extreme case of laryngeal edema. I think this would be a grade 3 for the Foldy. And so, yeah, that can be useful for, I think, for research, certainly. And so, you'll see these scales maybe used for like physical therapy papers for lymphedema therapy, and there's a whole group of people who like research that kind of thing. And then you do have patients that have progressed to bilateral vocal fold paralysis. So this patient has kind of a less than 2 millimeter airway. And that is another reason, you know, I think these patients won't need to have a salvage, they won't need to have a functional laryngectomy. They'll often just have a tracheostomy. But you can also just have bulky supraglottic scarring and edema and end up with an airway tracheostomy needed for that case as well. So, you know, there's a number of reasons that voice outcomes can be problematic after radiation therapy. There are predictors in terms of radiation dose, for instance, for hoarseness. And then another interesting thing is xerostomia. And I guess I don't know if this is like an established thing, but I've been giving patients nebulizers with saline to break up like small punctate crusts that are on the larynx. And I saw one of these patients back like 2 days ago, and it's pretty interesting the difference that I was able to see just by turning a dry mucus debris into something a little bit more moist. And then, you know, obviously, you know, speaking is a dynamic process. So there's tilting of the larynx and and all sorts of movements that get fixed as the larynx scars. And there's other predictors as well for poor voice outcomes. And so indications for a functional laryngectomy is often chronic aspiration. So I always ask these patients who've had organ-sparing treatment whether they've had pneumonia in the past year, and maybe count up the number of pneumonias they've had in recent years. You know, I think for patients that have dyspnea, I think they can often be managed with a tracheostomy. You know, in their study, they also included hemorrhage. I think that's also, it's not very common. And so I do think I think that, you know, aspiration here was very high in their patients. And we could talk about laryngeal preservation for recurrent disease. So again, if you, let's see, is Rob there?
Say it again. Rob's here.
Rob's here. So what are your options? Let's say you have a patient that has a T3N0 supraglottic tumor, and they go through chemoradiation. What options does the patient have if 4 months later they're noted to have a recurrence in the epiglottis?
You do like a supracricoid laryngectomy?
Yep, you could do that. What other option? Let's say the patient. Why would you not do a supracricoid in everybody?
What was that?
I mean, a supracricoid is not eligible for everybody. There's certain limitations. What about Karthik? Why would you not do a supracricoid laryngectomy in everybody?
If patients have poor pulmonary function, you shouldn't do it.
Yep. Yeah, that's probably the main thing. And Karthik, then what would you do for a patient who has poor pulmonary function if they have a recurrence in their supraglottis?
If they have a recurrence in their supraglottis, I would think about taking the box out. I think for pulmonary toilets, for restoration of swallowing, I think that's probably the safest thing to do, even though it's a more morbid procedure.
Yeah, so that's a salvage laryngectomy. So I think that's a very strong answer. And so another possibility for patients that have you know, a small recurrence that's resectable is transoral laser microsurgery, or maybe more and more transoral robotic surgery. So this is a case that I did for a patient who had just a very small volume recurrence of the right side of his laryngeal surface of the epiglottis, and I was able to to bisect the epiglottis and resect the epiglottis and a retinoid, you know, essentially performing a hemi-supraglottic laryngectomy. So that can be an option. This actually gave the patient durable control at least for 3 years. And TLM can be used for recurrence. Obviously, patients may have more issues with healing because TLM, there's not any closure of the defects. You may have exposed cartilage. And so this is TLM being used for salvage, looking at overall survival for early stage cancers. They had this is up to 5 years, they had greater than 60% overall survival. that does decrease for patients with advanced disease. And then similarly, you can see the figure for disease-specific survival. That's more of the same. This is local recurrence versus laryngectomy-free survival. So again, for early T-stage, more likely to be able to prevent salvage laryngectomy. And so this is one of the issues of salvage laryngectomy is prolonged pain and chondral necrosis, because these exposed cartilages are not going to heal. But still, the majority, you know, I suppose if your plan was to do a total laryngectomy for the patient, the majority of them were able to get by without chondral necrosis. And so for those patients who do have complication from TLM, they could always be salvaged with laryngectomy. Yeah, so here is some indications for some contraindications for supracricoid laryngectomy. So like Karthik was saying, poor cardiorespiratory reserve, again, surgical factors like extralaryngeal extension, subglottic extension. You need to basically have at least one functional cricoarytenoid unit that you maintain. But if you started off with a retinoid fixation, that would also preclude you. And so I think that a lot of people use, you know, there's multiple partial laryngeal surgical procedures, but I think that it's hard to, these are done less and less, and it's hard to be a kind of a master at all of these partial laryngeal surgeries. I think a lot of folks will rely on the supracricoid laryngectomy as their salvage procedure. And so this is a demonstration of the open supracricoid laryngectomy, maintaining at least one cricoarytenoid unit, and in this case, removing the supraglottic tumor along with, in this case, some of the true vocal folds. And then you basically have to compress the larynx and sew the hyoid down to the cricoid. And there's also a form of supracricoid laryngectomy where you include the epiglottis in this, but in this case, obviously, the epiglottis is resected. And so you have a couple very, very strong sutures that are holding everything together. And here we have, you can see true cricoarytenoid units that are maintained. And this is a lateral view looking at the suture technique where you're coming through the cricoid and then grabbing some base of tongue tissue and coming around the hyoid to compress it all down on itself. And so this is a cricohyoidoepiglottopexy. And so in this case, they were able to include the epiglottis into their suturing. And it's not a very great picture, but that's basically what I got. And so it can be a limited airway, and it is sort of compressed, you know, onto itself. But these patients will often have a very wet voice. So let's look at the next slide. Yeah. So they have aspiration. They need to be able to tolerate their aspiration and worsen voice quality. And so I think people argue that there is some potential for better quality of life, but if you're tracheostomy dependent, you know, perhaps you haven't gained very much. And so that's pretty much it. I think I think overall, I think probably the most interesting thing, and I hope to see more of it in the future, is chemo selection for laryngeal preservation. And potentially, I do wonder whether if you're able to treat these patients in a chemo selection paradigm and potentially decrease radiation doses down the line, whether you could have better functional larynx after a non-surgical treatment for these patients. So I think it's probably where we're going to see most interesting things happening in terms of the chemo selection protocols.